Hello, everyone. Good evening, good afternoon, good morning from wherever you're joining us. Welcome to this Mental Health for All webinar brought to you by the Global Mental Health Action Network. My name is Raj, and I'm going to chair this event. The session is being recorded. We do encourage you to tweet and share things that you like. So please use the hashtag MH for all when tweeting about this webinar. Do feel free to tweet. This session will hopefully last for 45 minutes. I will try to keep good time. If you have any questions for the panelists, please send them to webinars@unitedgmh.org or just write them in the chat box. Before we start, I'll just introduce the Global Mental Health Action Network. This is an open community of mental health professionals that are about over 1,200 members from over 90 countries, and we come from academia, governments, UN agencies, the private sector, and civil society. It's the largest global mental health network of its kind in the world. And currently, the network convenes working groups on youth and child mental health and financing, but will also be launching working groups on communications, research, and suicide decriminalization. For anyone who would like to join the Global Mental Health Action Network or to find out more information, we'll be sharing those details on how to do so in the chat box. Okay, so enough of introductions. Um, we have this webinar today because there has been a historic neglect in funding for mental health. Less than 2% of national health budgets globally are spent on mental health, and in low and middle income countries, this figure drops to less than 1%. So let's hear from our panelists on what the upcoming trends and opportunities are for mental health financing, and what are the priority areas for this type of investment. And of course, this has never been more critical than now, since COVID-19 has had a devastating impact all around the world. And I cannot be more excited to announce our panelists for today, who I will introduce, and then we can get into things. But very happy to introduce Ben Dossen, who is the country program lead for mental health at the Carter Center in Liberia. He works on a wide variety of things, but also works with the Liberian government agencies, universities, and other stakeholders, with a specialization in implementing projects related to the national mental health agenda. We also have Dr. Dan Chisholm, who is a social scientist with expertise in public health, mental health policy and economics, as well as health systems research. He currently works in the mental health unit of the World Health Organization Regional Office for Europe, which serves to support national mental health policy, planning and evaluation, as well as provide guidance, tools, and advocacy for the promotion of mental health. I'm also very excited to announce our panelist from Kenya, Douglas Otieno, who is the executive director of TINADA Youth Organization. Now, this is a community-based organization that is in West Kenya, working on integrated mental health rights education and campaigns, child and youth empowerment, sexual reproductive health, and disaster risk reduction. Douglas was telling me that they also have interests in research. And finally, Dr. Valentina Iemmi, who is an LSE Fellow in the Department of Health Policy at the London School of Economics and Political Science. She has over 10 years of experience in global mental health research with a focus on policy and financing. So I'm going to get right into questions, and I'd like to ask Dan, is it possible for you to give us a quick overview of the current financing situation for global mental health?
Okay, thanks, Raj, and good afternoon or good morning, everybody, and great to be here. It's a big question to start with, but I'll try and answer it perhaps with respect to three kind of key issues concerning mental health financing. So one of them is sufficiency of funding, The second one is around the efficiency of the money that is out there, and also the fair equity in financing. So when we talk about the adequacy and also the distribution of funding for mental health, as you mentioned at the beginning, it's still very low and inadequate relative to the needs of the population, especially in low and middle income countries. So huge variations exist from $1 per capita up to $200 or more per capita. But globally speaking, yeah, around 2% perhaps of government spending on health goes to mental health, aggregate estimate. And of course, that's far short of what many regard as a minimum amount, which would be more like 5% of government spending on health should be going to mental health. And of course, in some of the richer than some of the OECD countries, it's 10% or even more. So let's move to the second one, because I know we're short on time. So it's about the efficiency. And I think we still know that a large amount of the money that is available for mental health goes into outdated, not very nice places called mental hospitals or asylums. And only a fraction is actually being spent in the community or in general healthcare settings. And an even smaller amount is made available for mental health promotion and protection activities. Although the more you move away from specialist services, the harder it is to actually capture or measure the amount of expenditure. So it's hard even to measure the amount of mental health work goes on in primary care, let alone through other sectors to do with, let's say, child protection or youth-friendly services. And then the third one is about the fairness in financing. This is the equity. And actually, according to the latest WHO Mental Health Atlas data, a surprisingly large number of countries do include conditions like psychosis and depression in their national insurance or reimbursement schemes. But when you look into the detail, you still find quite a considerable number of countries where individuals or households are expected to pay entirely or substantially towards the cost of care, and particularly that's for medication. So together, those costs together with foregone opportunities for income and employment mean that the reality for many individuals and households who are affected by mental illness are at risk of impoverishment and also social inclusion. And that's obviously just got worse in the last year. So over from me.
Thanks so much, Dan. I've never quite heard it said so succinctly in 3 words: sufficiency, efficiency, and equity. I really like that. So I'm actually going to shift gears and look at a more national stage now. And I'd like to ask you, Ben, about what the state of mental health financing in Liberia is looking like.
Thank you, Raj. So, well, that's a tricky one too, but financing in Liberia is largely donor-driven and out of pocket. Overall, one can say that the government has demonstrated remarkable effort really to prioritize health in the country. And that has led health to be one of the sectors with the lion's share of the national budget every fiscal year. But the financing situation is challenged due to donor dependency and largely a poor population. We know that donors have their priorities and their funds, which can fluctuate, are primarily directed at those priorities. Often, mental health is not a priority of the major donors in the country. That, in addition to the lack of political will from the government, negatively affect the level of mental health financing in the country. That means, but not restricted to the constrained workforce, which impacts the delivery of quality care, limited and struggling facilities, which inhibit the provision of equitable mental health services across the country, and frequent drug stockout, which leads many people with mental health problems to relapse or end up in the streets. Though Liberia has a mental health policy, the mental health legislation, and even a dedicated mental health budget. The overall mental health expenditure has been less than 1% for many years. The target even for the current mental health policy, which expires this year though, it's about 23 million, but that was not achieved. Consequently, a significant chunk of the activities in the current policy will be transferred to the next period when it is revised. And the main partners in Liberia are the mental health partners, INGOs and faith-based institutions, which tend to be financially stronger, but are honestly not many in the mental health arena. And strategically, the government set up a technical coordinating committee, which all the partners serve on to share information, consolidate efforts, and advise the MOH. We see that the major mental health programs are implemented or supported by members of the committee, including MOH. But in general, the mental health unit, which is mainly in charge of coordinating activities, struggles to implement its basic functions due to lack of finance. And without the support of these partners, they may not be able to coordinate, monitor, or supervise mental health programs across the country. And the latest budget for the unit was less than $10,000. And on the other hand, mental health professionals across the country, they do not get adequate compensation for their services, and persons with mental illness continue to struggle. However, I would say, however, to look on the bright side, it is fair to say that attention for mental health has really improved in the country for the government and partners. Quite recently, we have seen a few more partners showing interest in mental health and even indicating plans to support mental health services. That in itself is an accomplishment.
Thanks, Ben. Great to hear that there is more of a focus now on mental health. And if I could ask Douglas, what is like from your end as an implementer? So what does TINADA do to increase affordable access to mental health services?
Thank you. We work in the 5 counties in the Western Kenya. And in Kenya, we have 47 counties. So we work in the 6 counties in the Western Kenya, Western part of Kenya. So one thing is that all the counties doesn't have budget for mental health. So one thing that we first did is to ensure that we have evidence-based information. We invest on research, we invest on data, because if you want to present this to county government and the county assembly and the parliament, then they will only act on the data. And we've seen that since we started with the research in 2018, we've seen the research have really improved on to ensuring that the county assembly are allocating money for mental health. And we will get that what we are pushing for is to ensure that every county is having a mental health budget code. So when they have mental health code in every county, meaning that whether TINADA is around or not around, then every year the county will budget for it. So we work with CSOs. We are not working alone. We work with a network of CSOs in every county to ensure that we push for mental health financing. And that this one we go through the executive, through National Assembly, through the county assembly, and through the county executive. And when we work with them together, then we've seen a lot of changes. Like for example, Kisumu, we've seen them right now. There's a mental health code, meaning that every year there's a finance for mental health. When you go to other counties, you will get that they have already allocated money for mental health. Now we are not doing that alone. We are now pushing for increase of that money, then tracking on the use. We can have money, but it can be used wrongly. So we are also tracking, working closely with the county government to ensure that this money is headed in the right direction. And also we are also working with the health facilities to ensure that the infrastructure has improved. You will get that in number of years, they were not funding for even infrastructure. But this time around, you'll get that in the counties you're working in, for example, Vega County, they've allocated money to establish 10 rehabilitation centers. And that's a plus because there's nothing like that within this region. In Kisumu County, there's a mental health code, and right now they have already increased that amount. And also, we're also working to ensure that there's increased human resource because there's no psychiatry. According to data that the research that we conducted, you'll get that there are so many people suffering from mental health, but there's nowhere they can go. You ask people, where can you go for mental health services? They will tell you none. And right now we've seen 2 facilities have been improved and there's money being allocated for that. And that's a plus. We are not only doing that, we are also working with the CS, so Civil Society Organization Network, to ensure that they integrate mental health into their valuable funds in other programs. And we've seen that happening, and we'll get a number of organizations now talking about mental health. And that's why we normally say, let's talk mental health. Then we also promote the community-based. That one will increase the service delivery. So the county now focusing on the working to ensure that the officers and the psychiatric nurses are available at the community level. These are the things that we do. Then lastly, we also ensure that there are commodities. The commodity supply by the county to these hospitals are available. Because at some point you'll get that they are not even, these commodities are not even supplied, or they will supply the commodities which is not needed in a certain area. So with evidence-based advocacy, we advocate for financing and the right, because every individual has a right for health. And that has really, we've seen that happening within the Western region. And even the National Assembly and the Senate normally come to this region because we work with parliamentary caucus to ensure that we advocate at the county level and also at the national level, because at the national level, they need to increase the percentage of money. That is when the counties will also receive the money at the county, then help to support the services at the community level. So what we are also promoting is ensuring that we promote the prevention. So mental health must go to the community. The services must be free. The services must be payable, and also the centers that are available must have the service providers, and they must also be neat. So those are the things that we do, and we've seen a lot of improvement in this. And everybody is now coming on board to talk about mental health. The last week, we had a meeting with the county assembly, and you will see that they are allocating number of increasing resources for mental health, and now they're also increasing resources for construction of other centers, which is very key, and that is the way to go. And one thing I want to say before I finish is that we must have evidence. That is when the policymakers will allocate money for mental health. So let us invest in research, and also ensuring that after this money is allocated, can we track this money so that it should be used in the right way? And also, we also need to push for and promote the community-based mental health care. Thank you.
Thanks so much, Douglas. So you've left us with some questions, and I'm going to ask Valentina, based on her experience in global mental health, about what she thinks the upcoming trends and opportunities for mental health financing are.
So I think that when I look at upcoming trends and opportunity, I can see 2 main trends and 1 big, gigantic opportunity. So the 2 main trends that I can see can be summarized in 2 words: proliferation and integration. Number 1, proliferation. I think there is an increase in number of organizations and individuals that are already investing in mental health, and plenty more that could be investing in mental health. And I think it's important to say that this is not only a proliferation in number, but also a proliferation in type of organization that are involved in mental health. So for example, until now, we were used to think about governments, development agencies, foundation, and pharmaceutical companies. Now we know that the reality is changing very fast. And we know that the reality is much more various and varied as such. We do have an incredible array of organizations in the public, in the private, in the third sectors, but also across multi-sector partnerships. So this is number one, proliferation. Number two is integration. So what do I mean by integration? I think we have been seeing an increasing use of the integrated strategy when designing investment. This means that mental health is increasingly integrated in investment in different areas. For instance, in different health conditions such as HIV, in different sectors such as education, employment, and broader themes such as gender, disability, or youth, for example. And this is an enormous advantage, not only for mental disorders, but also for amplifying investment in other areas. So those are the main trends. Now, the big opportunity that I can see is COVID. COVID has been an horrendous, horrible experience, and it continues to be an horrible experience for all of us. But now that's the time when we're starting the discussion about recovery and resilience for future threats. In particular, when we're thinking about financing, we are focusing on recovery budget and recovery funds. And this is an incredible opportunity for us, an opportunity to bring mental health at the forefront, leveraging on the existing trends that I just flagged up. So it's important to include all actors. Remember, number one, proliferation, and to integrate investment across different areas. Remember, number two, integration.
Great. Thank you. So taking a leaf from what you said, integration and including all actors, I'd like to ask Dan about what has been learned from the national mental health investment cases undertaken through the UN Interagency Task Force on Non-Communicable Diseases, and what are the next steps for this type of work?
Okay, well, let me quickly explain what those investment cases are. They're being supported through the UN's Interagency Task Force on NCDs, and they use a standardized approach and methodology that's been developed by WHO and UNDP. I'll put the link in the chat in a moment. And to date, there have been several of these investment case analyses conducted in Philippines initially, and then while in Uzbekistan, it's nearing completion. And then we have three in Eastern Africa, Kenya, Zimbabwe, and Uganda. And so these investment cases include a so-called institutional context analysis, where you try and understand, the ways in which the health sector is organized and financed generally, and then specifically on mental health. And then it also includes a sort of economic analysis of the costs and benefits and the return on investment for a range of treatment and prevention strategies for, leading contributors to disease burden. So I would say on the plus side, these investment cases, they can garner a lot of new policy interest and traction. And that's because you're converting things often into sort of dollars, which might mean more to, ministries of finance or planning than if you're talking in, epidemiological terms or public health metrics, like DALYs, for example. They kind of glaze over when you start talking about those. So I think it reaches, the parts that other analyses can't reach, which is a good sign. And of course, they can and are producing, substantiated new evidence for policy on what would be the expected gains resulting from greater investment in mental health. But on the downside, I would say right now, they're still largely just technical reports. In other words, they're decent pieces of work, or they're still being planned. But until, as we know, analyses are actually acted upon and they don't mean that much. So I think the real test is whether these investment cases actually lead to greater investment. And it's a bit early days for that. So we need to give some time. But I think, part of the next part of this would be that, need to follow up on the investment case analysis and ensure that there are people who are reading it and taking it seriously and able to maybe think about how the proposed investments could come into fruition. So overall, I'd say a useful new tool and approach, that can complement other efforts and inputs into decision making. And I think here it's really important when we're talking about investing in mental health that we don't just think in financial or economic terms, which is just one, people think immediately of money when they think of investment, but there are strong arguments quite apart from the financial ones for investing in mental health, whether that's the human rights argument or equity argument around reducing social inequalities or social exclusion. So when making the case for mental health, investing in mental health, it needs to be a combination of economic and equity and public health arguments that are put forward.
Thanks so much, Dan. If I could ask Ben about his experience and what work the Carter Center has done on financing and mental health in Liberia.
Thank you again, Raj. So in Liberia, the Carter Center mental health program really started around 2010. And to a large extent, the focus has been on addressing their needs and integrating mental health services into primary care and across other conditions, and also supporting sustainability. So there were originally three main pillars laid in consultation with the Ministry of Health. So one has been workforce development and sustainability. And in this area, the Carter Center has been working to build a new cadre of mental health professionals. So in collaboration with the Ministry of Health, the Nursing Board and other regulatory boards, the training institutions, they developed a 6-month post-basic course, and they train mental health clinicians who are then licensed by the board to go and practice across the settings. And they've even supported continuing education and also work with pharmacists in this area. So that has been the strong, that's been the flagship program of the Carter Center. And these clinicians have been integrated across facilities everywhere. And so they are the backbone, you say, for mental health service delivery in the primary care system, and even in some of the school-based projects. And in terms of the second pillar has been law and policy. And this has to do with supporting the development of the mental health policy and legislation, and also supporting the implementation of those instruments. And on that side, the Carter Center continues to help by increasing the clinical capacity of mental health professionals by doing more training and for mental health professionals, even training them on the middle healthcare workers on the WHO MHGAP and the integrated guidelines, and also helping to develop a local faculty who will be able to pass on training to other Liberian folks. And this also has to do with increasing the treatment centers. So in Liberia, there is one referral center for mental health. So all the cases are brought to that area. So the policy mandates that there be wellness units integrated at the county hospital. So the system of architecture is that people get services when they go through the hospital, so that they don't have an isolated structure. So, and the center has been working to help set up these wellness units. So they have minimum beds for inpatient, but they provide significantly outpatient services, kind of helping to increase access while at the same time reducing the burden on the referral hospital in Monrovia. And the center has also invested in building the capacity of a research center, again, something mandated by the policy to have a mental health research center, which is meant to inform standards based on evidence and also serve as the major repository for mental health services data in the country. And on the part of human rights and inclusion, the center has had very strong engagement with the government, local partners to help establish a very vibrant mental health service user movement. And this movement was very instrumental in the passage of the mental health legislation and also the passage of the first mental health budget. It was only recently that we had a mental health budget, and the service users were at the door of the legislative building, demanding that lawmakers pass this budget. And they were promised when the lawmakers came and said, okay, we will pass the budget, and that was done. So we've seen the force, of the advocacy. And lately, consistent with what Dan talked about regarding the investment case, the Carter Center has been working with United for Global Mental Health to conduct a financing study to make the same, first of all, to understand the financing landscape in Liberia, and then to make that investment case and help to increase the attractiveness of fundamental health in Liberia and get government involved. But there was also a strong advocacy component, because part of it is to build the capacity of civil society organization to advocate for investment in mental health. So we were able to do that study, and it's currently being reviewed, and hopefully maybe by the end of this month, the report will be launched. It's very good. It presents different scenarios for improving investment in mental health, and which makes sense for the context, the environment we're in, giving a large donor support and everything. So that's where we are. That's what the Carter Center has been doing in general regarding mental health and financing in country.
Thanks so much, Ben. We're really looking forward to hopefully getting the report at the end of this month, and hopefully there'll be lessons for us all from it. So we are running a little short on time, so I'm going to request our panelists for the next two questions to keep their responses to about 2.5 to 3 minutes. But Douglas, if I could ask you, if there was more financing available for mental health in Kenya, what would be your #1 priority investment? I think you're on mute, Douglas.
Thank you so much. What we believe in is prevention. And I will really go to ensure that we focus on the prevention. Based on the research that we did, there's a lot that needs to be done in the community. And the community, we ask them a number of community members, and the research revealed that 78% of people within Western Kenya prefer community-based mental health services. So as TINADA and CSO working in this region, we feel that investment need to be taken to the community. So we must ensure that we invest in community-based mental health care. I'm talking about it because it is very important to prevent more people to go to the hospital than investing heavily in the hospital. Then we get more people in the hospital. We are going to use a lot of money in the hospital. We are going to ensure that we hire human resource, a big population of human resource, because so many people are moving to the hospital, than investing in community-based. So that's why I say that mental health service delivery, and we must ensure that we focus on the primary health care. So investment should go to primary health care. And in Kenya, we implement community strategy. That is where we see, but all this cannot work because there must be the legal and policy framework. We must ensure that there is a legal and policy framework strengthened just as from national and the county government. I think we need to ensure that
So Douglas, if you could just repeat the last, I think, 10 seconds of what you spoke, it may have been lost for a lot of us.
Thank you.
Yeah.
I was talking about ensuring that we also invest in research and monitoring and evaluation, because the main reason the policymakers will tell you that they cannot invest in mental health because they don't have data. The Ministry of Health that is of data, and we're working with the ministry at national level to ensure that right now they enter the specific mental health related issues in their database so that the community health workers on the ground can do this. We work with support groups and we work with peer educators that are promoting mental health. And I feel this is a very good model that need to be replicated so that we prevent early cases of mental health at community level. So investment should go at community level, but we must ensure that we invest in monitoring innovation so that the policymakers need to get the data for financing to make a decision, because they will ask you, why do you want us to fund mental health? Yet we don't have data. There's no data showing that it's a serious issue. And I think COVID-19 really brought about the issue of mental health. And I think a number of policymakers are now seeing the sense of investing on mental health. So it is very key to promote legal framework at the county level and national level, then promote community-based mental health care, and also ensuring that we do a lot of monitoring and evaluation with a very good system. I'm not saying that we don't need to concentrate on
So I think
Thank you.
thank you, Douglas.
Thank you.
Now moving to data and more evidence, let's hear from Valentina. You recently published a paper on the motivations and methods of external organizations investing in mental health in low and middle income countries. Can you give us an overview of what you found?
Yes, sure. So in the interest of time, we will try to be short, so that we're gonna have some time for questions. So in my new paper, I'm looking at external organizations investing in mental health in low and middle income countries over the past 3 decades. And in particular, I'm looking at 3 points: how this organization have invested, why they have invested, and what are the opportunities for the future. So how they have invested. They have invested in such a broad array of ways. We can see some of those activities are within the organization, in particular activities aiming to strengthen the organization mental health, such as mental health awareness training or mental health support for the workforce, and activities aiming to strengthen the organization mental health capacity, such as introducing a mental health advisor or a mental health community. And some of the activity have been done outside organizations, in particular investment through, for example, standalone mental health programs, or as we have been seeing across the discussion in this panel, integration of mental health into existing programs. So second, why does organization have invested? And when we are considering the different factors, there are so many factors at many different levels, at the organization level, at the country level, at the global level. But across all this level, the most important feature, the key driver, were actors. So within organization, leaders and champions. In the source and recipient countries, political leaders. And at the global level, advocates in the shape of charismatic individuals, but also and foremost grassroots organizations. Then finally, what are the opportunities for the future? So if we're looking at these three different levels, organization, country, and global, we can see three crucial elements that would help spur investment in the future. First of all, strong leadership for mental health and strong understanding of what mental health is at the organization level. Second, increased political support, both at the source country and recipient country level. And third, a stronger governance structure for mental health at the global level. So in summary, a stronger leadership, a stronger political support, and a stronger governance structure will be crucial for increasing investment in the future.
Thank you. Thank you for that overview of your paper. We will switch over to questions now from the audience, and the chat box has been very busy. So we will try to pick some questions. I think the first question speaks to Dan's point on efficiency of funding. And the question is, what should go into qualitative case studies that will help shift investment towards financing for upstream intervention? Example, community-based services and primary care and away from hospitals and beds.
Yeah, thanks for that question. There were a few others which I'll try to sort of quickly answer in my sort of summary remarks. So yeah, I mean, look, the investment case kind of work helps to sort out some of these things. So for example, it can show that you get a better return on investment by putting your money into community-based rather than hospital-based care models. When it comes to kind of prevention and promotion, sometimes we lack strong evidence, but there is enough evidence for some interventions. So examples would include, for example, social emotional learning programs for preventing depression, anxiety, self-harm in school-age children. You know, we have that built in. You know, sometimes we run into a bit of a roadblock, you know, in terms of not having all of the interventions in this tool, you know, that we use. So that's still work to come. But the other question was about, you know, where do we get the money? You know, so we make the case, and then, well, where's the money coming from? And of course, COVID does provide, you know, an opportunity. So, you know, a key requirement is to work hard and ensure that mental health and psychosocial support are integrated into country recovery and resilience plans. There are huge amounts of money being made available from the European Union, World Bank, everyone. There's billions out there. So it's trying to claim some kind of share. And of course, the more you have kind of some homework, some data, as was being said, you know, the better chances you have on making that claim. So there's the link. And another question was just around, you know, another source of big money, you know, is in other areas, whether, let's say, for maternal and child health. And you have things like the Global Financing Facility. And it's been a struggle to date, you know, to get properly incorporated in there. But there's huge opportunity for actually, you know, building in a mental health component of those sort of applications. So there is, and we have the data and the evidence, but sometimes maybe we don't have the strength of partnerships or links with people working in those other sectors. So it's something to be worked on.
Thank you, Dan. That was illuminating. Our next question, I think, could be answered by any one of the panelists, since all of you have background in research or are passionate about research. But the question is, what about the burden of care on caregivers who are mostly women? Has there been a measurement on that economic burden, or is it being measured? And if so, who is measuring?
I can go.
Sure.
Thank you. One thing that I said that need to be strengthened is research and community-based mental health care, with focus on having data, ensuring that we have a very good system on monitoring and evaluation. This is not happening. And the data being collected at the community level, it is just indicating mental health. But we have so many categories of mental health. This is not there. And that's why it's very important. I don't know what happening in other countries. We are working very strongly to advocate with a number of CSOs and working closely with the policymakers to ensure that this one is included in the data form. And number of institutions, including government, need to ensure that we target this. Community health workers are doing very good job. The caregivers are doing very good job, but we are not investing in the research. We are not investing in monitoring and also seeing the magnitude. We don't know the strength of the suffering. So we cannot say, how can we support what we don't know? So we must ensure that we invest in monitoring and evaluation at the community level and ensure that we have evidence-based. That is when we can implement evidence-based intervention. And that is when we can also ensure that we advocate effectively. Thank you.
Thank you.
Brad, maybe I can take a stab.
Lovely.
Just to speak to that, but specifically to maternal mental health. So what we do in the Carter Center in collaboration with the Ministry of Health is to roll out the Thinking Healthier program. Thinking Healthier is evidence-based psychological intervention for managing perinatal depression. And just from the short work we've seen, and after training just a cohort of healthcare workers and starting their field practice, the number of women with pregnant women they've come in contact with who have depression and really score high on the PHQ-9, many. And so with this approach, the idea is that they will benefit from the 16 sessions of the Thinking Healthier program, and then we will continuously monitor that work, screening them to see how their depression drop and how well they are coping. And we've seen some very strange cases of mothers with postpartum psychosis and depression who do a lot of different things, and people perceive them to be bad, they're evil moms, and perceive them to be possessed by demons and all of that. So with this integration, so to make Thinking Healthy a part of the overall maternal and child health toolkit to support women. So yes, we're trying to collect the information. We have a very strong research approach to document everything properly and show the evidence, and use this to speak to the government when we should have put everything together to say why it is important for us to do this integration, why it is important for us to support it.
Raj, can I say something, or we are too short?
Please.
Just to follow up on what everybody's saying, and I've been looking at the chat, there are a lot of cross-sectional thinking, especially in the chat, which is great. It's absolutely great to see. And I think in the comment from the panelists, the big word was thinking about other areas, thinking about opportunities, not only in mental health and mental health services, but thinking diagonal. The big thing would be for us to start building some cases. And I think that Dan was absolutely instrumental at the WHO to start building this big economic case. And we have other people around that are now starting with this work. With the burden of care, for example, there is this big discussion about the economy, the care economy. So that's not only relevant for mental health, but you can log into a bigger discussion and bring your mental health perspective on it. Maternal care, as Ben said, we do have many interventions that can plug into maternal health. Physical care and palliative STEAM, again, a big area, and we start to have some evidence. The big issue would be now to be vocal about, to have a clear message, some clear facts and number to say, this is what we can do, and this is how much we need in order to do it. So I think the possibility and the opportunities are multiple. It's about us to being able to grab them.
Thank you, Valentina. So the chat box is blowing up, and I think people can continue the conversation on social media. But for now, I'm going to continue with what we have left to do. And I'm going to put pressure on all the panelists, starting with Dan, to give me a one sentence or a short and snappy answer to what is your top priority to increase investment in mental health? It has to be a tweet length answer.
I think I've said it already. So to ensure that mental health and psychosocial support is incorporated within country recovery and resilience plans, because that's an opportunity that should not be missed. And actually it ticks all the boxes in terms of what many of the strategies we want to pursue in any case. Over.
Thank you. Great. Now, if I can ask Douglas, in one short sentence, what's your top priority to increase investment in mental health? I think you're on mute, Douglas.
We must ensure that we work closely with the government and we work in equal partnership. And this work, you cannot manage it alone. We work jointly with the community, we work with the CSO, we have worked with the private sector and the government, especially the policymakers and the executive. And when we work with them, then automatically there's going to be improvement of health. And the key is to ensure that there's a mental health code in every government. Because if there's no mental health code, they can give it funding today, but what about tomorrow? But if there's a mental health code in the budget, then whether you are around or not around, every year it will be budgeted for. What is important now to ensure that we are okay for increase of financing, and also to ensure that we track what is available. We track to ensure that it goes on the right way. Thank you.
Thank you. Valentina, if I may ask you for the same.
Yes, so I have two short sentences. So people have people have the power as citizens, users, and consumers. United and clear voices from the bottom will change the top.
That is absolutely brilliant. I love it. Thank you. Finally, Ben, if you could also share, what's your top priority to increase investment in mental health?
My top priority would be to integrate mental health across all levels of care and conditions, because it's cost effective. This can help reduce stigma, and this can help us to maximize the already low resources that we have in country.
Great, thank you. This has been an absolutely fabulous and scintillating conversation. So I want to thank my panelists. You incited so much great discussion on the chat boxes as well. So thank you so much for being part of this, and thank you to the participants of the webinar for joining us for this very important discussion. And now the recording and the notes of this session will be posted up on the UGMH website shortly. I will also be chairing the next session, focusing on this year's World Health Assembly. And you can visit the UGMH website to join, and email webinars@ugmh.org to submit questions in advance if you'd like. But for now, thank you so much. It's been absolutely fabulous talking about this to all of you and have so many people participating. Thank you, and have a good day or evening.